Our next two speakers are Dr. Andrea Chapman and Dr. Amrit Dhariwal. Dr. Chapman is a clinical associate professor in the Department of Psychiatry at UBC. She graduated from UBC Med School in 1994 and is a psychiatrist here. She's the medical director of the Consultation Liaison Service at BCCH, providing inpatient and outpatient assessments. Her area of interest is in pediatric somatization, and she's co-authored Patient and Family Resources for Professional Resources and conducted research on group therapy for somatization. And she's a program director for Child Psychiatry Subspecialty Program at UBC. Dr. Amrit Dhariwal is a clinical assistant professor in Department of Psychiatry at UBC. She graduated from York University Clinical Psychology Program in 2012. And Dr. Dhariwal is a registered psychologist here at BCCH. Her area of interest includes treatments for pediatric somatization. Amrit works in a clinical capacity in the teaching clinic here, training psychiatry and psychology residents in family-based therapy and emotion-focused therapy. And Dr. Chapman and Dr. Dhariwal are going to be speaking to us about an optimistic and practical approach to pediatric somatization. Thank you.
Okay, so I'm just going to acknowledge that we're starting about 15 minutes late. So some of you may need to be places at 12, so feel free to leave if that's what you need to do. So I'm really pleased to be here and speaking with you along with my colleague, Dr. Chapman, who will join in a few moments. So today we'll be talking about an optimistic approach to pediatric somatization. I'll be giving a little bit of an overview. Dr. Chapman will take us through sort of the identification and assessment process. I'll go through a bit of the treatment, and then we'll do a case example at the end. So we have no disclosures to make between the two of us. And we also want to acknowledge that this is not just our work, but the work of many people who have collaborated with us, in particular Dr. Teresa Newlove and Dr. Liz Stanford in the psychology department. So our goals are to, 1, increase comfort in managing somatization, 2, to develop a framework for understanding and treating somatization, 3, to share a bit about some practical tools and resources, and also share our optimism and enjoyment in doing this type of work. So somatization is a really tricky concept to define, and often people have different definitions in mind when they think about this. In our work, we simply call somatization the experience of emotions in the body. And so we know that emotion systems prepare us to meet challenges encountered in our environment, for example, by activating cardiovascular, skeletal-muscular, neuroendocrine, and autonomic nervous systems. So it's really normal to experience emotions in our body, and we use the word somatization because soma means body. So there's research to show that it's actually very normal to experience emotions in our body. This picture is from some recent research where they had individuals from different cultures. I think they had like almost 800 or more people in the study. And they were told stories and given photos that elicited various emotions. And then they were asked to indicate where on the body they would feel the emotion, or that they felt the emotion. And so to interpret this picture, basically red means activation and blue means deactivation. And so what was found is actually there might be some universal ways we all experience emotion. So emotions like positive emotions like happiness are shown all over the body. Depression and sadness are more shown in the limbs as a deactivation. And sort of anxiety and anger are sort of like up here and sort of activating us. So somatization is a process, and it only becomes a disorder if it interferes with our everyday functioning. So in the pediatric population, this is estimated overall to happen about for 8 to 13% of kids. And it gets in the way of everyday functioning like school, going out with friends, recreational activities. And so I'm going to turn it over to Dr. Chapman to do the next piece.
So I'm going to talk a little bit about the challenges. I think all of us probably have found it challenging to work with families, children and families who have somatization. So I'm going to talk about the challenges because that helps us understand the model that we're going to walk through. So we've developed a model based on like 15 years of our clinical experience in this field. So in the 17th century, Descartes proposed that the body and the mind were very separate. So the body was like a machine and the mind was non-material. And this has obviously influenced, or this had a big influence in Western medicine, Western science and medicine, and that although we understand way more about mind-body connection now, and we're getting back towards a more integrated system, that has continued to have an effect in terms of our systems being unintegrated and some of our concepts of disease and disorders being unintegrated. So we asked 47, and a number of you here were part of that study. We asked a number of you, 47 pediatricians from 11 different subspecialties, what disorders are associated with a really strong component of somatization or are primarily somatic in nature. And you guys came up with these different diagnoses, which makes sense that there are different diagnoses because these are different body regions and everything, and they are different in their expression. But there isn't a common unifying language. So that's challenging for us. There isn't a common somatization as the closest we have, but we don't use that language usually. So what families end up hearing when there's such a disparate language is that your child is faking it, or the kids hear that it's all in your head. That's one of the challenges that we know. Another challenge is that children and youth who somatize tend to be internalizers. So they internalize their emotions and thus their body speaks for them. And this kind of exemplifies to me a little bit of that. So what happened, I had a patient who I'd been working with for quite a few years and had conversion disorder. And I asked her to do a task that we often do. So draw in her body, in this drawing, where and how much she felt different emotions. And you can see that she labeled happy. The blue is happy. You can see the label on the bottom. And she drew a little bit of tired around her head, but otherwise just a tiny bit of sad, angry, and worried. But I actually knew her, and I knew she was in a lot of distress. There were a lot of things going on in her life. And so I expressed kind of, questioned her about it. And then she said, "Oh, you mean what's on the inside?" And then drew this picture, which showed all these distressing emotions, as well as some happiness internally. So that was a bit of an aha moment for me, where I realized that the kids with somatization have a very different internal world than what they show on the outside. And that's we all have that. We all have an internal world that we're not showing. We should have that. But these kids, the disparity is really large. So what parents see, teachers see, everybody else sees is 2 thumbs up, happy smiles. And so if you as a treating team are trying to tell the parent or the child who isn't very good at recognizing some of those more distressing emotions that their physical symptoms are caused by an emotion, stress or distress, it doesn't make sense. So that's another challenge we have. And there are a number of other things. So we end up in a situation where we're confused and the kids are confused. I'm going to just play a few minutes of a video that we created. So we interviewed 4 patients and their parents, and 4 sets of parents, over who had been through the treatment here in psychiatry and psychology. After they were kind of well treated, so they went through this journey with somatization. We interviewed them later and then transcribed their interviews and tried to make sense of these phases, or their journey. And we came up with some phases, which I'll show you in a minute. Then what we had is we hired some actors that took out the salient features. So we have a 20-minute video that's on the Kelty Mental Health website. And the first part of the video is about confusion.
to look back, but your story might be helpful to others.
Basically, if I think back, it started with these like crazy headaches, which was weird because I'd never had headaches before.
Before, it used to happen like 50 times a day. That's why the principal told me I couldn't come to school anymore.
Can you tell me what your first visits to the doctors were like?
I was going to a lot of appointments, and I went to emergency a bunch of times.
They like sent me for a bunch of tests and like CAT scans and stuff.
And what did they say?
They all said it was something different. One doctor said it was a sinus infection.
I was really confused as to why I was sick.
I knew my parents were really worried that it was something bad.
So then it goes on for another 20 minutes. I won't do the whole thing. But, so what we found is that there's these typical phases of confusion to begin with, and then we get into a phase where people are starting to understand the connections into integrated treatments and recovery. And people can go back and forth, and you can have a parent that's in a different stage than a phase than a child. But our job is to kind of help move everybody towards recovery. So I'm going to go into each of those phases a little bit. So in the beginning, and we think these phases actually apply to us too, as the healthcare practitioners. So in the beginning, we're all confused, and we may not be as in the healthcare world, we may not be certain about the diagnosis, but we also are often confused about how to convey the diagnosis or the formulation. In the connections phase, the patient and the family learn about the diagnosis and about the mind-body connection, and they start to understand mind-body connection, how emotions can affect the body. In the integrated treatments phase, they're actually engaging in multidisciplinary and multifaceted treatments that are appropriate for somatization and any medical condition that they might be having. And then in the recovery and functioning phase, they're back to their usual lives. And so what we love to see is when the kids come in and they start complaining about their parents, or they're, worried about their homework, but they're complaining about normal teenage things. And they're not coming in talking about their pain or whatever physical symptom they have. What's really interesting is in lots of times, if you ask them about their symptom, they'll say it's as bad as it ever was, but their functioning is fine. So we don't worry about it because it's gone from the forefront of their mind to the background. So I'll switch now to our treatment model, and it's really based on those phases. So if you look on this side, you can see the confusion to recovery, and then the different components on the other side. And we'll go through all of those. So our goal in treating the kids, our joint goal as a team, is to help move through the phases as efficiently as possible and with as least distress. We also really think of this as an opportunity. So I'll often say to the kids that I don't ever wish that you were going through this and that you had this symptom, but my hope is in this process you're going to learn a lot more about yourself, and you're going to learn tools for the future that are going to be helpful for you. So to go back, in the component, in the confusion stage, that's really the presentation and assessment phase. In the connections, and again, I'm going to go through this in more detail. Connections phase is where we're really providing the diagnosis and understanding of the diagnosis, explaining the mind-body connection, and coming up with a treatment plan. And then we get into integrated treatments, which is the treatment plan, and Amrit's going to speak more about that in detail in a few minutes. And then our favorite phase, which is the recovery phase. So we're going to switch to tips and tools and resources. Each of the things that we're going to talk about, we could talk about the two of us could talk about for hours with you guys. So there's a lot more information, but what we've tried to do is just highlight a few things that's most useful for you. So starting again in the confusion phase, this is assessment phase. So it's important as pediatricians to be assessing and investigating thoroughly. And we would suggest in this phase that it's sometimes important to have therapeutic assessments or investigation and referrals. So we don't want anything that's going to cause iatrogenic harm, but it is worthwhile being very thorough. We work a lot with a neurologist, and they will often order MRIs even if they're not sure or think that it's probably not necessary, but the cost is well worth it if you can move the family forward. You prevent a lot of dysfunction and other things occurring. This time you're also assessing for psychiatric disorders, temperamental traits, and stressors. Kids with somatization tend to be, not always, but tend to be perfectionistic and, like I said, internalizing. So it's important to try to understand your patient. A couple of caveats here is often so often in this process, the youth and the children may have anxiety and depression, but it's very hidden, and so it's not easily accessed in this stage. That's why it comes out physically. So we may not see psychiatric disorders, and sometimes they aren't there, but there's a much higher rate of anxiety and depression in somatization. The other caveat is that we never ever make a diagnosis of somatization on the basis of anything psychiatric. So and I always say the diagnosis is not mine to make. So even though it's considered a psychiatric diagnosis or mental health diagnosis, I'm not the person that takes the history of the physical symptom, or does the physical exam, or looks at the investigations and compares that to what I know in that area. So even though there may be psychiatric disorders or stressors, the diagnosis is not made on that basis. Moving from that assessment phase, if you have a good sense that there is a strong somatic component, then we're into the diagnosis and formulation stage, and that is obviously really individualized to the practitioner and the family, what you're comfortable with. But what we really strongly suggest is what we would call a positive diagnosis. So a diagnosis that makes sense but gives a label to the process. And so something like medically unexplained symptoms to us is quite unsatisfying, and to families is quite unsatisfying as well. We like the term component of somatization. So that could be, there was a viral illness and now there's a strong component of somatization, or concussion with a component of somatization, or ARFID with a component of somatization, because that really reflects the reality. We don't necessarily have these discrete bodies. It also allows you to have some uncertainty to say maybe there is a medical condition, we're not sure. Or, I will tell my patients all the time, I have migraines. I'm not sure when I have a migraine what component is somatic and what component is more biological. They're both kind of mixed up, right? It's the mind-body connection. So, and then families are generally accepting of that term. I think another term to use is mind-body connection, which actually people are really familiar with these days. So in the connections phase, a few concepts that we found are helpful are that component of somatization, but also this notion of walking two integrated paths. And quite a few of you know Teresa Newlove. So she came up with this phrase, and by that we mean we are going to be with you and help you and support you walking the medical path and the somatic path. So meaning that you can continue to have assessments and treat medical treatments. We hope that they're not iatrogenic and not prolonging things, but if not appropriate. But we also at the same time really want to support you and encourage you to treat the emotional part, the psychological, the psychiatric part of this. And if you do that, then the families don't feel like they're shunted from the medical world to the psychological, psychiatric world. We worked with a number of people, Zumbo being one, and I can't list all the people, but in our integrative health working group, we spent about a year trying to figure out language that we like that helps families understand somatization. So we wanted something that normalizes, is transparent, and normalizes the experience that they are having. So we came up with this, and we use this pretty verbatim with almost all of our patients, and we use it in our groups. So we say all emotions have a physical component. Soma is a Greek word for body. Somatization is the word we use to describe the physical expression of emotions and stress. And then we go around the room and we all give examples. So I'll give an example of migraines, and we get, like, if there's a grandmother in the room, we get her to give an example. And so we go around, and again, that's really normalizing because we all feel stress in our body somewhere. Everyone experiences somatization. The symptoms are real, and it can occur on its own or alongside any other medical condition. And as you guys all know, most medical conditions do have a component of somatization. Stress makes most, stress or unhappiness makes most medical conditions worse. Other things that can help punctuate that understanding, we have some resources on the Kelty Mental Health website, a brochure, the video that we just showed you, and we're developing right now an animated video that really explains the science behind kind of the fight or flight system and the science behind the mind-body connection. So that should be out in January. We have a family, we're just in the final stages of our family handbook that we can give, and it's like a 30 or 40 pages of information for families. So that'll be up there soon. And there's things like the frequently asked questions in there. And there's some resources that I've been working on with my colleagues in the States that'll be on a website there. The other thing that we wanted to let you know about is our mind-body connection group. So this is really, has been very exciting and fun for us, although also daunting. We are now in our 10th group. So we have a group where we have the teenagers and older children and teenagers and their parents come to our group. It's 6 sessions over 6 weeks, and we meet all together, but then we separate. So the youth and the parents are separate in separate rooms, and we talk more about somatization, mind-body connection, and then some of the reasons for somatization or stress in people's lives. What we found is that it pulls families along and kids along much more quickly. If we, rather than us telling them about what's going on for them, they pull each other along. And so we can move through those phases. And some of our really, really stuck patients have come through this group and done really well with that. And then the last part of this connections phase is coming up with a treatment plan. And that's where we will, and you can too, is using the brochure or whatever plan framework you have. We print this out, and then we go through each area of this with the kids and the parents to say what needs to happen now, what can they do, who are some of the care providers that can help in those different areas. And Dr. Dhariwal is going to talk a little bit more about that.
Right, so I'm just going to go through that wheel, and then there's parts of this that various multidisciplinary clinicians provide, and there's parts that you provide. So the first thing that's often provided, ideally before discharge, is developing a symptom management plan. And so this is more of a practical plan to help kids cope with their symptoms or their pain. So one part of the plan might involve medication, and that's in your wheelhouse. Another part that might involve is more on behavioral strategies. So things like diaphragmatic breathing, progressive muscle relaxation, and also things like graded exercise therapy. So these are more about a plan, what to do when symptoms come up. And often these are provided by psychologists or physiotherapists, but almost anyone can provide these types of supports. There's some really great online tools to help with some of these. And I think Dr. Zumvo will be presenting later about his breather app. That's the first one on our list that we like. So all of these professionals are integral. Physiotherapy is integral to the treatment plan. And so there might be different pieces involved for different kids. So balance and pacing is more of another behavioral approach, just getting kids activated, getting them back going to school, and how to do it in a manageable way. So a pacing approach really involves taking baby steps. So day 1, you might only be able to run 30 seconds and moving up from there, for example. And the other half to that is preparing the environment for the child as well. So what are the parental expectations or the teacher and school expectations around this? And so this part that excites us the most within the mind-body connection group, the part we focus on a lot is sort of the psychosocial aspect and the emotional aspect. So in the treatment we do, for example, we might ask kids to consider what are all the tasks of adolescents that normally they should be working on. And these are some of the things that we have in mind, for example. And it's really interesting to go through sort of a Socratic questioning experience with them to get them to think about what are the things they're working on. And often what we see is the kids that we're often treating, they're really thinking about like academic tasks or things that they need to do in that way. And they're not really thinking about all of the other tasks that they might be falling behind on because of somatization. So, you know, getting into conflicts with parents, that's a task, or connecting more with peers than with other people, or experiencing lots of different emotions and figuring out.
Disconnected.
Another